here at the Journal Club. We are very, everybody knows Bihong. Bihong is associate professor from University of Texas in our beloved city of Houston. I hope it's not that hot so far right now, right? She is very experienced. She is our council member for the first term, second year. And she is very experienced in cardiovascular pathology. In practice, she covers both autopsy, heart and lung service. So the topic is interesting too. I think it's a little bit different opinion among pathologists, talking about the similarity and difference between germ cell myocarditis and cardiac sarcoidosis. Very interesting topic. Thank you, Bihong, please.
Okay. Let me share my screen. Can you see my screen?
Yeah.
Okay, very good. I'll go to presentation mode. Hi, everybody. Good afternoon and good evening. If anyone joined from China, it's good morning. So I'll start the Journal Club of this month. As Peter already introduced me, and so I just skip that part. I will start with one case. I have been through this case for a couple of times, starting from biopsy until the patient died. So that's the reason get my attention to this entity. Let me see, where's the patient's history? Oh, here's the patient history. The patient is a 62 years old Asian male. He has a history of complete heart block a few years ago, 2022, and atrial fibrillation. He first showed up in our institute in February this year. The presentation is very interesting. It's a continuous, very intensive hiccups for a week. I don't know why, I have no explanation of that. It was so bothering. He could not sleep, he could not eat well. So he came to emergency room. So at the time we checked on him, he was found suggestive of cardiac shock. She was diagnosed with non-ST elevated myocardial infarction with 25% ejection factor. And later on, she was found very high level of troponin and the peptide, BNM peptide. So right after that, they did a heart biopsy. What is that? So here's the heart biopsy I got in a Friday afternoon. So you can see the biopsy very small. Even in a low power, you see the heart is covered with inflammatory cells. And also in high power, you can see there's a lot of myocytes necrosis and damage and dropped out. Here, you can see a giant cells here. I highlighted with the star. Here is another view of this biopsy. I realized there's a lot of yields, And actually, my first diagnosis in my mind is eosinophilic myocarditis. And then later on, I found more giant cells. So then I called this giant cell myocarditis. I hope everybody agrees with me. So later on, the patient was undergo a lot of treatment. Immediately, the clinician added immunosuppressant medication and a lot of intervention, but eventually the patient passed away. The family decided to transfer him to comfort care only. He passed away in March 28th. It's about 1 month in the hospital. Then I did an autopsy on this patient. The heart is slightly heavy, but on the card section, you can see there's a lot of fibrosis. On the lateral wall of the left ventricle and also anterior wall of the left ventricle, in the septum and the posterior wall. And under microscope, here is the microscope, AC node. And the low power, you can see there's a lot of blue cells and clustered blue cells. And here's the AV node. Again, there's a lot of infiltration, inflammation. And the high power, you can see all these clustered blue cells are multinucleated giant cells. I hope you agree with me, there's no granulomas. These giant cells alone is not a real granuloma. So, but on the other hand, the patient has a lot of fibrosis in the heart, especially it's kind of patching, kind of granulomatous material in the heart. So based on the previous history of complete heart block a few years ago, so there's a question on the diagnosis. Is the patient have a sarcoid, cardiac sarcoid before and kind of burned out and they superimposed giant cell myocarditis, or it is just the combined or single giant cell myocarditis? So that's the question. And myself and my supervisor, Dr. Bouya, we go to the literature, then we found this paper. Manifestations and outcomes on cardiac sarcoidosis and idiopathic giant cell myocarditis by 25 years nationwide cohort. So there's a lot of authors here. I put a map here. There's a group of clinicians and scientists from Finland. So when you say nationwide registration, it's from Finland. The background, cardiac sarcoidosis and your idiopathic giant cell myocarditis are rare, but serious inflammatory cardiomyopathies affecting mainly middle-aged adult. The details of their pathogenesis remain unknown, but autoimmune disease-related myocardial injury mediated by T lymphocytes and triggered by infectious or non-infectious agent has been incriminated in both. Cardiac sarcoidosis and giant cell myocarditis share many histopathological and clinical features. Whether they are parts of one disease continuum has been discussed. The method of their study. The study population, authors included in the present work a total of 310 patients with a lifetime clinical diagnosis of either cardiac sarcoidosis or giant cell myocarditis, and 69 similar cases diagnosis only at autopsy and identified in retrospect from the cause of death registration. Basically, it's from ME office. So I have two sources of patients. One is from the register, lifetime clinical diagnosis, or from autopsy cases. The clinical cases series was based on the nationwide registration of myocardial inflammatory disease in Finland. I was wondering if American has this registration registry. I have not heard of that, but I think that's a good idea. All these cases are entered in this register. And compromised patients admitted to and diagnosed in the Finnish university and the main provincial hospitals from the late 1980s until the end of 2015. So 25 years. The postmortem cases were identified by screening of total, that's a large number, death certificates available in the digital form in the National Cause of Death Registry from 1998 till the end of 2015. diagnostic criteria and reassessment of original cardiac sarcoid diagnosis. So for the sarcoid diagnosis, they require presence of a non-necrotizing epithelial cell granuloma and the multinucleated genital cells, sharply demarcated area of inflammation and fibrosis, and the absence of considerable myocardial necrosis or abundant tissue eosinophilia. So that is the histological diagnostic criteria from for the sarcoidosis. Then plus the clinical feature, presence of clinical signs of myocardial involvement, high-grade AV block, heart failure attributed to left ventricle dysfunction or ventricular arrhythmia, together with the findings compatible with inflammatory cardiomyopathy in either PETs or cardiac MR or echo. So that's clinical information. You have histological evidence of sarcoidosis. You have to be non-necrotizing epithelial granuloma, genital cells, a lot of inflammation, sharply delineation. So that is the histology criteria plus clinical evidence of cardiac involvement.
Bihong, before you go further, so I have one quick question here. So they are either in the histology, either in the heart or in the extracardiac organ or lymph node, right? This one, the classic
yes,
histology.
in this, yeah, histology could be in other organ.
So they have a breakup, say, you know, how many are from heart, how many
Yes,
from
yes, later on I have a cutoff. I have the how to say that, yeah, I will have one. So for the, where is the slide? Oh, genital cell myocarditis, you have to see myocardial damage, absent of granuloma, present of multinucleated genital cells, amid a mixture of inflammatory infiltrate of histiocytes, lymphocytes, eosinophils, and plasma cells, and also plus the clinical information. And then they re-evaluate all these cases because they are afraid they have to apply their diagnostic criteria for all these cases. And eventually, as many as 19 out of 24 cases was filed genital cell myocarditis and reclassified as sarcoidosis because they found granulomas. So as long as they found granulomas, they put them into sarcoidosis category. That is in the cause of death category. And the 25 out of 49 cases included earlier as genital cell myocarditis in the register and reclassified as a sarcoidosis. So here it is, answer your question, Peter. For the 351 cases of cardiac sarcoidosis, 224 have myocardial, either biopsy or explant heart or autopsy. There's 102 from lymph node, and the extra cardiac have 25. Does that answer your question?
Yeah, that's a pretty significant number from extra cardiac tissue.
Yeah. And they collect the information about the patient, the demographics, clinical cardiac manifestation, associated disease, as well as result of diagnostic images, and the laboratory studies, and details of treatment with drugs and the device. So they record all this information from the file. Data collection, and here actually is repeat. The cases identified from the cause of death registry were mainly individuals dying from suddenly and unexpectedly undergoing forensic autopsy. There are medical documents were acquired from the local hospitals and health centers, and their past medical history, as well as any cardiac symptoms, examinations, and treatment shortly before death were recorded. So here is the definition of a major adverse cardiac event, because they use these words a lot. Major advanced cardiac event that include cardiac death, aborted sudden cardiac death, heart transplantation were recorded and analyzed as a major adverse event. I think that's the end point of their study. That's defined as this way. Aborted cardiac death was a documented episode of ventricular fibrillation terminated successfully either by an implantable cardiac device or external defibrillation during resuscitation for a cardiac arrest. I think this means successfully revive the patient. That's what I understand. I'll see how they use this definition later on. So that is their statistics. For different measurement, they use different statistics. I think that's very complicated. I will show their result as I'm going on with this. Here's the result. Here's the table 1. The first column is characteristics. They put on patient's age, sex, main presentation, sudden death, a different category of sudden death, comorbidities, and the duration of illness. Here on the right side, all these abbreviations. I just highlight the category has a significant statistically significant, because they said less than 0.005 is considered as statistically significant. So heart failure is a significant statistic in their analysis. So giant cell myocarditis caused much more heart failure than sarcoidosis. The other thing, age. Age is significant. Looks like giant cell myocarditis have older age than sarcoidosis as significant. Age should have more. What else? Yeah, I think in this table, just these two are significant, statistically significant.
Duration of illness also.
Duration of illness, the last one. So, yeah, I should have another box. I missed that one. And yes, giant cell myocarditis is much shorter duration, and then sarcoidosis much longer. Here is the second one. That is the image. There's also clinical data. Let's see, again, the left ventricle ejection fraction is significant in the less than 50% situation. So look at giant cell myocarditis has more. But if it is over 50%, they do not list as a significant difference. But overall, the left ventricle ejection fraction has a significant difference. The other one is this pro-brain natriuretic peptide. It's much, much higher in giant cell myocarditis and lower in sarcoidosis. And also cardiac troponin T, but not troponin I. Troponin T is significantly higher in giant cell myocarditis. So it's also from a clinical side. I think that's all for the significant difference. Oh. Treatment. In the sarcoidosis patient, left presentation, 278 received the immunosuppressant treatment with prednisone. And I believe all these cyclosporin, but that's not a steroid. It's a steroid and the immunosuppressant combined. Myocarditis is also immunosuppressant with variable combinations. Of the 25 patients with giant cell myocarditis patient during life, 7 were administered with prednisone alone, and 14 received the triple combination of prednisone, azithromycin, and cyclosporin. Then the intervention cardiac device, implantable cardioverter defibrillator was implanted, 181 in sarcoidosis, and 13 in giant cell myocarditis. So both 60% versus 50% received the pacemaker. So that's the summary of the treatment. Long-term follow-up and its predictors. For these 3, I have a question about why the original from 351 patients, eventually they only analyzed the 311. I think it's because the follow-up time. Some of them just lost the follow-up. So the 311 sarcoidosis patient with the lifelong disease presented had a total follow-up time ranging from 6 months to nearly 30 years. It's really a long time follow-up. So here is the divide them into groups. 39 died, 32 sudden aborted cardiac death, 9 deaths of non-cardiac issues, cancer, TB, dementia, and brain infarct. That's the cardiac sarcoidosis group. Among the 25 giant cell myocarditis patients with total follow-up time from 3 days to 19 years, means 3+ years. 7 fatal arrhythmia and heart failure, and 7 sudden aborted cardiac death. But anyway, that is the overall outcomes. And some of them follow the heart transplantation. Here is the table, long-term follow-up and the predictors. Again, we try to find out what is the most significant finding. The diagnosis is very significant finding. Diagnosis of giant cell cardiomyopathy, myocarditis versus sarcoidosis is very important to separate. The other thing is heart failure, which we mentioned earlier before. The other one is, again, ejection fractions, important, and all these peptides. So corticotropin and the natural uretic peptides measured at the onset of follow-up were predictive of endpoint event. So that's their point. When I recall my patient, the case I presented earlier, my patient had a very high level of troponin. So that's the support diagnosis of giant cell myocarditis. Here is the previous table they presented in the graph. They tell the same thing. Giant cell myocarditis a much shorter time of event-free survival and transplantation survival. This one, they add more other factors put into account. Looks like giant cell myocarditis, it's bring it up a little bit. So that is the summary, put them together. 5-year event-free cardiovascular survival was 77% in sarcoidosis versus 25% in giant cell myocarditis. It is statistically significant. And this one is use another multi-factor, multivariant, use Cox regression method. I think that they separate the model 1, model 2, model 3. I try to find out what's definition for model 1, model 2, model 3. Basically, I think model 3 is the most severe one with a very high level of troponin and natriuretic peptide. So they put the discussion. Our observations show a similar end-to-end spectrum of presenting cardiac manifestation with a relative predominant of left-sided heart failure in giant cell myocarditis versus high-grade AV block in sarcoidosis. In giant cell myocarditis, circulating cardiac troponin, the natriuretic peptide, were more often strongly elevated, but the left ventricle had the polar ejection fraction, but less dilatation, suggesting a more extensive and more acute myocardial injury compared with sarcoidosis. Event-free survival was worse in giant cell myocarditis. So in the discussion, they cited 3 previous studies. And then I just briefly cover this previous study. They do the comparison. I think it's Dr. Jovesky is in our society. Probably he's not here today. So they did 8 heart with giant cell myocarditis and 7 heart with sarcoidosis. You can tell the case number is much smaller, both by histological histiocytic giant cells. The main discriminator being the absence of myocardial granulomas in giant cell myocarditis and necrosis in sarcoidosis. Eosinophils were frequent in giant cell myocarditis, but not in sarcoidosis. So it looks like they have much smaller case number, and also they did not include the clinical features, basically on histologic. That is one study they cited. The second study they cited is this paperwork, clinical and histological combination of cardiac sarcoidosis and idiopathic giant cell myocarditis. They have more cases, 73 cases of giant cell myocarditis and 42 cases of sarcoidosis collected from nearly 50 institutes nationwide. So that's widespread in the whole world. Myocardial necrosis and granulomas were seen in both conditions, though necrosis was more intensive in giant cell myocarditis, and the granulomas more common in sarcoidosis. So they did not say not there, but just the more in sarcoidosis. Eosinophils were more frequent in giant cell myocarditis, and the more fibrosis seen or more extensive in sarcoidosis. Left side heart failure predominantly in giant cell myocarditis was syncope, and AV block was seen more often in sarcoidosis. The 5-year transplantation-free survival was 60% in sarcoidosis versus only 10% in giant cell myocarditis. So I think their findings compared to the paper I'm talking about are very similar, pretty much the same findings. There's a third paper that's recited. Improved the diagnosis of giant cell myocarditis and cardiovascular. They used the gene expression profile. So they point out 28 genes in 10 patients with sarcoidosis and 10 genes in giant cell myocarditis in endomyocardial biopsies. 5 genes, 2 coding for cytokines, and 3 for mitochondrial energy metabolism show the differences, differential expression. So they suggest use molecular study, gene expression to separate these 2 entities. They did find some differential expressions. I don't know how useful it will be or how we can use this information in the future, but I believe it's not frequent. So what the study adds and suggests, our comparisons of echo details added to the literature by showing that septum thinning, considered as a hallmark of sarcoidosis, was even more common in giant cell myocarditis. I did not know that, but anyway, that's supposed to be in the image study. At the same time, left ventricular dilatation at the presentation was more frequent in sarcoidosis. The data on cardiac troponin and the natural uretic peptides are also novel and show both biomarkers were much more frequently elevated in giant cell myocarditis. So that T is a typo. So that is their add. They think they add this information to the clinical literature. So the final come to the question, it is 2 disease or it's 1 disease with varying phases. Our findings and the scrutiny of the past literature suggest that cardiac sarcoidosis and giant cell myocarditis may rather be either closely related types, twins, or T-cell myocarditis, or severity phenotypes of a single disease. So maybe that's single disease, just different severity. In the later case, giant cell myocarditis would represent an aggressive form of isolated cardiac sarcoidosis. At the same time, fulminant giant cell myocarditis with a rich eosinophilic infiltrating has a histology and clinical resemblance with necrotizing eosinophilic myocarditis. So clinical resemblance, necrotizing eosinophilic myocarditis. So like in my case, when I see the biopsy with so many years, my first diagnosis in my mind is, oh, eosinophilic myocarditis, until I found the giant cells and changed my mind. So in a Lewis rat experiment model of giant cells, giant cell and necrosis are present, but the tissue eosinophilia is missing, as is myocardial granuloma formation, even during the late phase of the condition. So let's talk about animal model. they generated Janus-cell myocarditis model. In that model, you see Janus cells, necrosis, but no granulomas, no eels. And there's no model for sarcoidosis. They talk about their strength and the limitation. The strength is the population. They include the cases of cardiac sarcoidosis and then Janus-cell myocarditis over 20 years in our country. So it's a long history, many, many cases. We complete the study group with cases diagnosis at the autopsy and identified from cause of death registry. So the weakness, limitations, and talk about all this population is from their own country. It doesn't have the generalizability and accessibility and manifestations of sarcoidosis and the Janus cells, because we know sarcoidosis is much more higher frequency in Africa, Americas. So they don't have the data from this population. 1/3 of sarcoidosis history and of sarcoidosis was confirmed from extracardial biopsies. So that is weakness of their study in confirmation with the current recommendations. Key limitation of our study is that considerably number of cases were included in retrospect, such as all those diagnosed before the year 2010 or post-mortem. That's a significant limitation. That's what they think. The availability and use of diagnostic method changed over the 25 years. And the certain important examinations like a cardiac image with PET or MRI measurement, therefore missing in many, many cases. So the early time, they don't have the PET or MRI and the cardiac troponin and the peptides. Here is the conclusion. The present comparison of a 25 years cohort of histopathologically diagnosed sarcoidosis and the Janus-cell myocarditis shows that those conditions have a similar end-to-end spectrum of clinical manifestations, similar female preponderance, and a similar coexistence of autoimmune disease. They are distinguished by the severity of acute cardiac injury and the dysfunction and by the long-term outcome, both being worse in Janus-cell myocarditis. The case of whether cardiac sarcoidosis and Janus-cell myocarditis are unique, and the different entities or subgroup of a single disease cannot be brought to any issue without in-depth basic research, settled in their pathogenesis. So still no clear cut. We need in-depth basic research and find out the pathogenesis. And back to my case, I think the patient currently have Janus-cell myocarditis for sure, but I'm not sure if the patient have early years have a sarcoidosis. So that's just review my case. I think that's the end of my talk. We can start, open your microphone and speak out, ask questions, discussions, or welcome.
Thank you, Bihong. It's very interesting. We have more questions than answers, apparently.
Yeah.
So any comment? Well, people are still preparing. One thing from your presentation, I think the Janus-cell myocarditis only 25 cases, right, in your cohort, and Sarcoid is about 325. It's a huge difference, right? That is one observation, which I think is pretty impressive. Another thing you know, the idea of it. So if these are two entities or only one entity at different stage.
Mm-hmm.
So maybe your case gave a pretty good example, actually. So, you have, when you at biopsy time, it's a very active, it's infiltrative, has a lot of eosinophils, and then later on, it become a little bit granulomatous, more contained. See, I think time, if we have more cases like that, within certain time, after certain time, you may have a better answer, even with clinical samples. That's my gut feeling. Mark?
Which I really don't know. I have another autopsy case with a lot of fibrosis. I see giant cells, and then that even add more interest to me. I was just say, okay, what should I call? But I don't see granulomas. I just say a lot of fibrosis, a few multinucleated giant cells. The inflammation is not very intensive. So I'm going to call that sarcoidosis. It's because the fibrosis is more than inflammation. I really don't know if it really matters. But end, even the treatment is the same, steroid plus immunosuppressant.
Yeah.
Why they argue so much? If you can save the patient's life, and just do it. Whatever works. I don't know if this, sometimes, yeah, if I keep bothering myself on one question too long, my final question will be, does it matter to clinicians to save patients' life?
I think the one hope will be you develop some more effective therapeutics down the line, not now. But anyway, Mark, you have any questions?
Yeah, I have a couple questions / comments. The first is to your last point about steroids. That's true. Although interestingly, when I was at Johns Hopkins, if a patient was diagnosed with giant cell myocarditis, they would list them for transplant right away. Whereas for sarcoid, they would treat with steroids. So they use a different approach. Now, I know some places, I know the Mayo Clinic is just have high dose steroids and immune suppression, even for giant cell. That's the Cooper's approach. But there are different approaches there. So it would be great to know that. I love what you presented with your first case because Joe Malshevsky, myself, Brandon, and I think it was maybe Matthew Castaway, we looked at these intermediate question about whether there's this intermediate thing between obvious giant cell and obvious cardiac sarcoidosis. And your case kind of fits that spot as well. And we pulled all these cases we had of very obvious giant cell, very obvious sarcoid, and then ones that had features of both. Too many eosinophils to call it sarcoid, more pushing borders, but it looked like it should have been giant cell, and tried to see if there was something we could discern that figured it out, like whether this was an aggressive sarcoid or a latent giant cell. And we really couldn't solve it back then. We wanted to approach it. But there are people like Grover Hutchins who had a paper on long survival with giant cell myocarditis, like a 10-year survival case. And so and that paper is 20 years old. So this has been a problem for a long time, and I love that you're bringing it up. And I think there's times where we know it's obvious, it's giant cell or it's sarcoid, but there's these ones in between, and I think we're okay to say we can't really tell because no one knows for certain whether it's a spectrum or it really is one entity. I do think they're two different diseases, but there's something that falls in the middle, as you pointed out. So I think it's terrific.
Actually, my patient, it was listed for heart transplant if there's available donor, but eventually his situation developed very fast to become multi-organ failure, liver, kidney, and the lung, and eventually he's not good he could not survive for the heart transplant, so he just stopped.
So another observation is interesting in your paper, the Japanese paper. even you do transplantation, the survival is a little bit lower, right? 5 years survival of transplantation is lower.
It's because probably the high reactive inflammatory overall situation in the patient's body. And think about the troponin level that high, it's probably will not support the transplantation. Peter, can you, is there any way you can unmute Dr. Booya? He sent a text message to say he could not unmute himself. Dr. Booya, do you see that?
Tiana?
I don't know. You're the host.
It's Dr. Fallon. Can you hear me?
Yeah, we can hear you. Yeah, we can hear you.
Yes. Okay. Fantastic paper there, review, and great case. I just wanna bring up one diagnosis that I didn't hear you speak about, and that is Church-Strauss disease, which is Church-Strauss is granulomatous
granulomatous, yeah. Polyangiitis.
Myocarditis. Yes, and your patient sounds like that they might have had that disease rather than sarcoid or just everyday giant cell myocarditis. Although usually they have significant renal disease as well. So I just bring that up as a point. I didn't hear that in any of the papers because
put into differential diagnosis.
It should be part of the differential diagnosis. Absolutely.
Yes, agree. The question, I really, in my case, either in the biopsy or explant or the autopsy case, I really don't see clear granulomas. Yeah, otherwise.
Well, in Church-Strauss, you don't usually see very good granulomas. You just see very, you don't see the kind of granulomas you see in sarcoid. You see these very poorly formed, and you have to use your imagination. So I'll leave it at that. Yeah. Thank you.
Yes. Thank you. Any other comments?
Well, I like your idea to have a collaborative, like a registry stuff to study.
Yeah, do we have one in America?
I don't realize it. Mark, do you know anything?
I do not know. Leslie Cooper, I think, had a registry specifically for giant cell, but I don't think for sarcoid. The kind of thing that he would be the expert to go to. I see Max Booya posted something in the chat.
Yeah, earlier he just said that he could not unmute himself or start.
I see. So he sent it to me. He said, great presentation. Your case appeared to have burnt out sarcoid first and then giant cell. In the paper you reviewed, is there information as to what happened first, giant cell or sarcoid?
If there's two entities, I think the sarcoid happens first. It's a few years ago, the 2020, the patient have completed the AV block. I think it's AV block is more, just by statistically, your guess that's a sarcoidosis. The giant cells is a later event. That's my opinion.
Very good. So any more comment or?
So I think we have to keep debating on this.
Yeah, I think somebody from Washington University will have basic research supporting the same disease, but she is not here today. So, but that's where the basic research part will be. But anyway, I think it's a very, very interesting topic, and debating still going on, and need more exploration, and we will keep our eye wide open. Thank you.
Okay, thank you
Thank you.
everyone for attending.
Thank you. Good job.
Thank you.
Great.
Bye-bye.